So now it's actually time we enter into the main stage. It's my pride to introduce today Dr. Christian Falzone. Dr. Christian Falzone is a European board certified neurologist. He's actually very experienced in MRI. He started in the infancy of his career to work on MRI when he was a resident at the Clinica Monsumano Terme. Then he continued working at the Davis Specialty Centers in UK. And then he moved back to Italy, where he's now partner of the small animal diagnostic in Vicenza. For those that are not familiar with the geography in Italy, is very close to Venice. He's also president of the Italian Society of Veterinary Neurology. His main interest is brain and spine surgery. He's author of several international publications. And as far as I know, he enjoys a lot running, driving very fast cars. I don't know if you have so much time to spend, but I'm sure this is his main hobby. So now it's time to introduce Christian. Welcome, Christian. Dr. Falzone, thank you for your cooperation in making this course happen.
Thanks. So hopefully it's my turn now. So I really thank Erminio and the whole group of Esaote for inviting me for this hopefully very exciting, interesting, and entertaining 14 sessions. As Erminio said already, knowing the neurology is paramount for dealing with an MRI scan, since nowadays at least more than 90%, or at least approaching 90% of our cases, daily MRI cases, are neuro-oriented. So this is why it's very fundamental to be familiar with the neuro patient. So the main aim of this 2 or probably even 3 meetings is to become familiar with the neurological patient. So we start today with a neurolocalization to the spine, and then every other Wednesday we move on to the neurolocalization to the brain. And then on the third webinar, we see which are the major application of the MRI system to the neurological patient. And then we alternate, myself and Dr. Connor and Dr. Baldi, to tell you a bit more in depth about the MRI principles and also about the different diseases, on how the different diseases looks like on an MRI scan. And hopefully by the end of this year, as Erminio said, by December, you should be pretty able to recognize the major and the most common diseases, let's say so, affecting the brain and the spinal cord. So without spending any more time to this first webinar, again, I'll thank everyone for attending it, and we start with neurolocalization to the spinal cord. So hopefully now everyone can see the first slide. And we start to say that to be able to localize the problem to the spinal cord, you definitely have to be familiar with a few principles regarding the neurological exam. So, and before facing a few cases, we have to go through the major part of the neurological exam, which is made of observation and manual exam. Observation is a very important part of the neurological exam, too much often under-evaluated, but it's very important because, for example, in aggressive dogs or in some cats, the only thing we can do is to observe and to see what they do. And the mental status is controlled mostly by the brain. So by evaluating the mental status, we evaluate the brain, which is definitely the goal of the next webinar. So we go very fast on that, just saying that the major the structure more important for the mental status maintenance is the brainstem, as you can see in the drawing there, which projects diffusely to the forebrain. And this cooperation between brainstem and the forebrain gives this bright and alert status that the normal patient should have. moving a bit forward with the observation, we look at the posture, and the posture should include the observation of the head posture, the body, and the legs. So, and all those three things are controlled by the central and also the peripheral nervous system. Here we can see, for example, a dog with a head tilt, which is, as we will see in a few weeks from today, it's highly suggestive of vestibular disease. Here there is a dog with a neck ventroflexion, which could be either expression of severe weakness, like it was in this case, or neck pain. And this is a dog with kyphosis, and anytime you do see a dog, especially a dachshund like this one here with kyphosis, you should be very suspicious of pain disease, most likely a spinal pain disease. And this is a dog really badly affected from the neurological point of view, which was unable to sustain himself to have a judgeable posture. And then we move on to the gait. Observation of the gait is paramount for us as neurologists to start saying where the problem could be. And what we look at when we evaluate the gait from the neurological point of view, we look at the coordination and the strength of the gait. Anytime there is an issue with the coordination, we tend to say that the patient is showing any kind of degree of ataxia, which again means uncoordinations. If the strength is affected, which means the patient is weak, really weak, we tend to say that the patient is paretic, so is affected by paresis. So the two major terms we should be familiar with when we look at the gait are ataxia, which again means uncoordination, and paresis, which means a really weak patient. And historically, we say that the ataxia is a sensory deficit, which means that the coordination is mostly affected, and paresis is a motor deficit, which means the weakness is the key issue with that patient. For you to make difficult things very easy, there are three different types of ataxia: the spinal one, vestibular one, and cerebellar one. And as you can see from the names, the vestibular and cerebellar ataxia are pretty easy to be recognized because they are due to a problem either into the vestibular system or into the cerebellar system, which means beside the ataxia, there are other vestibular or cerebellar signs that make the ataxia very easy to be recognized. And the ataxia we're going to deal with for this first webinar is the spinal ataxia. So this is the major ataxia we should be familiar after the end of this first webinar. And here you can see an ataxic patient, which is really uncoordinated on all four legs, but the dog still maintains a certain degree of strength to move and walk. What the dog is missing is mostly the coordination. So it really looks like a drunk patient. So if you want to differentiate an ataxic dog from a paretic dog, try to think how you were if you ever been, or how you could have been if you got drunk. So if you get drunk, the first thing you lose is your coordination, and then probably even the wallet and the cell phone, but try to stay stuck on the neurological issues. So ataxia means uncoordination. Paresis, as we said already, means being really weak. And if the paresis affects only one leg, we say monoparesis. If the paresis affects two legs, usually the back legs, we say paraparesis. If all the four legs are affected, we say tetraparesis. If only two legs on the same side are affected, we say hemiparesis. So being familiar with those names is very crucial, especially if you have to refer the patient for an MRI scan, or if you have to assess your patient by yourself and you need to say what's wrong with that patient in terms of with the major aim to localize the problem. You should say if only one leg is affected, two legs, four legs, or two legs on the same side. If the paresis become really bad, it tends to progress from paresis to plegia or paralysis. Basically, plegia or paralysis means that there are no residual movements at all, as you can see in the patients there. So this is what we may say is a paraplegic dog. Para means back legs, plegic or paralytic means that there are no residual movements, no left movements on the hind limbs, okay? So this is a paraplegic dog, okay? So even a very bad paresis, we may define it as a non-ambulatory paraparesis or non-ambulatory tetraparesis, but when the paresis progresses to plegia, there are no movements left at all. So even if we support the weight of the dog is not able to move any single fingers. And here, just for you to become familiar with it, this is a monoparesis, okay? It doesn't make any difference from the neurolocalization point of view if only one leg or two legs are affected. The only thing that is telling you if only one leg is affected is that the spinal cord is mostly affected on one side. So if you see a dog like that, you can say that the dog is monoparetic on the right hind limb, which means that there should be a problem somewhere in the spinal cord, as we will see shortly, sparing the left-hand side and affected the right side. And this is another example. This is a more cranial disease affecting the spinal cord, as we will see shortly in the neck, because all four legs are affected, even if there is an asymmetry between the right hand side legs, which are still able to move a little bit, and the left-hand side, which are almost plegic. So we can say that this cat has an hemiplegia on the left-hand side. So it doesn't make any difference from the neurolocalization point of view, but it's telling you that there is one side that is bad and another side, which is the right in the dog on your left and the left-hand side on the cat on your right, which is affected. So after an evaluation of the gait, we have to assess the postural reactions. And then any other things as the pain. Just a few words on pain to tell you that pain, usually we don't use the pain as neurologists to localize the problem. We use the observation of the gait, the postural reaction, as you will see in a few seconds, and the spinal reflexes, if you wish, to localize the problem. And we use the pain just to confirm where the problem could be and to say what the most likely option could be, which means if the underlying condition is a painful condition, like for instance, a slip disc, or a non-painful condition, like for example, an intramedullary tumor, okay? But we don't use the pain, we don't jump straight on palpating the spinal cord to say if the dog is painful or not, and to localize the problem. What we do use to localize the problem is the observation of the gait and postural reaction, mostly. And about the postural reactions, the most important postural reaction is the proprioceptive positioning, but especially in patients like cats, we do the hopping. So we make the cat hop on one side or walk on one side, and we compare one side with the other. As you can see in this cat here, there is a decrease in hopping and walking on the right legs, and normal hopping and walking on the left legs. So usually proprioceptive positioning is not very reliable in cats, and this is why in cats we tend to do hopping or wheelbarrowing, for example. But in dogs, proprioceptive positioning is the most important thing we can do. And this is how we do the proprioceptive positioning. We bear the weight of the dog by putting an arm or a hand under the abdomen of the chest, in case we are assessing respectively the back legs or the front legs. Then we knuckle the feet, and then we evaluate the repositioning of the feet. And this is a video on how we do it. My left arm is below the belly of the dog, supporting the weight of the dog, and I'm knuckling the foot, and this dog here is unable to put his foot back in a normal position. So we can say that there is a proprioceptive positioning deficit on the right back leg. And the same issue is happening on the left hind leg. So not proprioceptive positioning on the left hind, and normal proprioceptive positioning on the front legs. Okay, so when we support the chest of the dog and we assess the front pose, the proprioception is entirely normal. Okay, so the problem in this dog should be somewhere along the spinal cord, affecting only the back legs but sparing the front legs. Okay, and what we want to say when we do the neurological exam in a spinal patient and in a neurological patient more in generally is if the proprioceptive positioning is decreased or absent. Okay, and in a few words, to make things very easy, answering to the question, is the proprioceptive positioning normal or abnormal, we can say if the dog has got or not a neurological problem. So for a dog with a spinal disease, in other words, it's very likely to have either ataxia or paresis and proprioceptive positioning deficits or hopping deficits if it was a cat. So if everything that I said so far is clear, we can move on to the spinal patient more in detail. So a spinal patient, as we said already, but we remark it, no problem at all, is a dog or a cat with ataxia and or paresis and proprioceptive deficits. And we rely on those to say what the problem is. And the spinal dog may have a disease in the cervical spinal cord or in the thoracolumbar spinal cord. And the cervical patient has ataxia, paresis, and proprioceptive deficits on all four legs. If the disease is affecting only the, let's say, 1/2 of the spinal cord in the cervical area, then only the 2 legs on that side will be affected. So let's say if the dog has got a cervical problem damaging the entire section of the spinal cord, both the right and the left legs will be affected. So the ataxia, paresis, and proprioceptive deficits will affect all 4 legs. If the damage is affecting only 1/2 of the spinal cord, ataxia, paresis, and proprioceptive deficits will be evident only on that side or more evidently on that side. Look at this dog here. Most of those dogs, I've seen most of the dogs when I was a very young neurologist in training with Massimo in Tuscany. So it's a nice weather. It's a nice part of Italy. You can see that this dog is very weak on all 4 legs, and we say paretic. So this dog is tetraparetic because there is weakness, which is severe weakness, paresis on all 4 legs, ataxia as well. So of course, ataxia and paresis may coexist in the same dog because sensory and motor fibers travel very close to each other on the spinal cord, and it's very likely for a spinal cord disease to affect all those fibers. So you may say that this dog has both paresis and ataxia on all 4. And when you assess the proprioception, you can see that there are proprioceptive deficits on the front legs and proprioceptive deficits on back legs as well. And again, it doesn't make any difference if only one side is affected or 2 sides. It's only telling you if there is one side of the spinal cord that is mostly affected or more affected than the other half of the spinal cord. But as you can see in this patient, ataxia and paresis were present on all 4 legs, like the proprioceptive positioning was absent on all 4 legs. When we look at a thoracolumbar patient, so the disease is centered on the thoracolumbar spinal cord, the ataxia, paresis, and proprioceptive deficits will affect only the back legs. So the front legs will be entirely normal. And this is a typical German Shepherd dog with severe paresis, which means severe weakness, but also uncoordination, so ataxia on the back legs. Of course, when there is paresis, the paresis tends to overwhelm the ataxia, so it tends to be more evident the ataxia. And if you assess the proprioception in this case will be absent or decreased on the back legs, but totally normal on the front legs. So ataxia, paresis, proprioceptive deficits on the back legs, thoracolumbar problem. If the same deficits are affecting all four legs, cervical problem. What about the lumbosacral patient? So the lumbosacral patient is a dog with a disease centered between L7 and S1. At that level, there is no spinal cord left, but there is more spinal nerve roots, which altogether we call them coda-equina nerve roots. And anytime you've got the compression of the coda-equina nerve roots, you don't have ataxia or paresis. Okay? So with the lumbosacral, with the pure lumbosacral problem, you don't have any degree of ataxia and paresis. So try to keep that in mind, which is really important for you to localize the problem. What you may see in a dog with a LS disease, you may see like in the patient here, a paretic tail, so a very weak or low tail carriage, but the back legs are pretty much normal, or they might be slightly stiff, rigid, and you may see, if there is a very bad lumbosacral problem, a certain degree of lameness, but you don't see anything else. And pain is always present with a lumbosacral problem. So you have to say that there is a lumbosacral problem, that there is painful, either at the palpation or, as you have seen right now, at the extension of the lumbosacral junction, you should say that there is pain. If there is pain there, you can be suspicious of a lumbosacral issue. But if your dog, beside the lumbosacral pain, also has ataxia or paresis, you should look more cranially to the spinal cord, but not at the L7 S1. Now, just based on the observation of the gait and postural reactions, you can say if the dog has got a neck, which means a cervical problem, or a thoracolumbar problem. But you can be even more precise and saying if your dog has got the cranial cervical problem, which means a C1, C5, or a caudal cervical problem, which means C62. Or even in the back, you can say if the problem is located in the T3L3 area, which means between the third thoracic and the third lumbar vertebra, or between the fourth lumbar vertebra and the first or third sacral vertebra, which means between L4 and S3. In other words, you can say if the cervical or lumbosacral intimacies are involved, are affected by the disease or not, by evaluating what? By evaluating the lower motor neuron, which is essential for the spinal reflexes. And the lower motor neuron for the front limbs is located between C6 and T2, and the lower motor neuron for the back legs is located between L4 and S3. So if the lower motor neuron is paramount for normal spinal reflexes, if we do see a decreased or absent spinal reflexes in the back legs, we can say that the lesion is affecting L4-S3, which is where the lower motor neuron is based for the back legs. Or if the spinal reflexes are normal on the back legs, we can say that the lesion spares the L4-S3 area and is cranial to that. So should be cranial to L4-S3. And if it's cranial to L4-S3 and the front limbs are normal, they don't have any ataxia on paresis, then the lesion should be between the neck and L4-S3, which means T3-L3. If all four legs are affected, then we test the spinal reflexes on the front limbs. And if the spinal reflexes on the front limbs are decreased or absent, then the lesion should involve the cervical intumescence, which is between C6 and T2. If the spinal reflexes are normal, so the lesion should be cranial to C6, which means C5, C1, C5. And the spinal reflexes that we test for the front limbs, the flexor reflex. We don't do any other reflexes like we were doing in the past, like, for example, the extensor capi radialis. The only reflex we do right now for the front limbs is the flexor withdrawal reflex. And from the back limbs, we test the patellar reflex and again the flexor withdrawal reflex. And this is how we test the reflexes. The patellar reflex, we hit the patellar tendon with a hammer, and we want to assess the extension of the legs. If the patient is not able to extend the leg, so we say, oh, is doing it really weakly, we can say that that patient, he doesn't have any patellar reflex, and as you can see in the patient here, the forceps, the dog still can see pain, he still can feel pain, but he's not able to flex the leg. So this is a dog with no spinal reflexes on the back legs. And now we assess the flexor withdrawal reflex on the front limbs. So the patient is definitely feeling pain, but this is not what we want to assess. We want to assess if dogs are able to show patellar reflex or withdrawal reflex. If they're not withdrawing their legs, we can say that the spinal reflex are affected, and then we can say that the disease is affecting the C62 intumescence for the decrease of the flexor reflex on the front limbs, and L4S3 spinal cord for the decrease of the spinal reflexes in the back legs. So if you have a dog with ataxia, paresis, and proprioceptive deficits in all limbs, the problem should be in the cervical area. If the spinal reflexes are normal, so C6T2 is spared and the lesion is C1, C5. If the spinal reflexes are abnormal, then the lesion should be between C6 and T2, which means the lower motor neuron for the spinal reflexes for the front limbs should be damaged. If you have ataxia, paresis, and proprioceptive deficits only on the back limbs, which means the front limbs are spared, the problem should be somewhere in the thoracolumbar area. If we want to say if it's more likely to be T3L3 or L4S3, then we have to assess the spinal reflexes on the back legs. If the spinal reflexes on the back legs are normal, that means that the lower intumescence, which means L4S3, is spared, and the lesion should be cranial to that, but caudal to the cervical area, because the front legs are normal, so the lesion should be T3L3. If the same dog with ataxia, paresis, and proprioceptive deficits on the back legs has got also decreased spinal reflexes on the back legs, of course, then L4S3 is the correct neurolocalization for this patient. If the dog has got paresis and proprioceptive deficits on all limbs, this is just something probably beyond the spinal localization, but just for you to be familiar, if you got paresis, which means severe weakness, and proprioceptive deficits on all four limbs, and the spinal reflexes are decreased on all four limbs, either you have two lesions affecting both the lower cervical and the lower lumbar spinal cord, but this is really rare, really rare in the daily practice. And that means that it's more likely for you to face a patient, to deal with a patient that has got a disease in what we call peripheral nervous system. So those dogs usually have got problem in all four legs. There is no ataxia because the key word is weakness. So those dogs are paretic in all four legs, and the spinal reflexes are decreased in all 4 legs. So if you are dealing with something like that, you can say that this is not a spinal disease, this is a peripheral nervous system disease. If everything that I tell you so far is clear, and I do hope so, I will move on with the first case. But if you have any question at this case, I don't know if Chiara is there, and we want to ask a few questions before starting with the first case. Is there? No? This is just, this is for the, after the case, Chiara, but this is just in case some participants, some attendants have got questions regarding what I said so far. Is everything clear what I said so far? If you've got question, I think you can type your question, and I can try to answer to a couple of them. Otherwise, I move on with the first case. Okay. Since there are no questions, we move on and we look at this dog here. This is a miniature schnauzer. Hopefully you can see the video. And now you have to observe. You should look at the gait of this dog. And you should say how many legs are affected. And anytime you've got issues with the gait, you have to say if the problem is orthopedic or neurological problem. Okay.
Christian.
So we start the video.
Christian.
Again.
Hello, Christian. Yes.
Yeah, I'm here. Yeah. I realized
there was a technical problem. There was a technical problem. There were no questions, and now we have to start back again. Thank you.
Yeah, no problem. Now you can see this miniature schnauzer here. As I was saying, anytime you've got issues with the gait, you have to say what you're dealing with, which means it's an orthopedic issue or it's a neurological issue. And anytime you do see a dog dragging the feet, you can say that this is most likely a neurological issue. And then you have to say how many legs are affected. So we can see the gait one more time. And I do hope that you are able to see that there are issues with the front leg and with the back leg as well. One side is more affected than the other. Then we want to confirm that what we are dealing with is a neurological problem, so we assess the proprioceptive positioning, and this is the proprioceptive positioning on the left hind. Try to write down on your notes there how the proprioceptive positioning is on the legs on the left side, the proprioceptive positioning on the right back, and then the proprioceptive positioning on the right front leg as well. I'll show very quickly again to you. So this is the dog. I have to support the dog because otherwise he's unable to walk. As you can see, there is one side which is definitely pretty bad. Proprioception on the left hind. What you have to ask to yourself if it's normal or abnormal. And if it's abnormal, definitely there is a neurological problem. How many legs are affected? Only the back legs or all 4 legs? As I told you before, if there is one side which is more affected than the other, it doesn't make any difference for your neurolocalization. Is only telling you that there is one side of the spinal cord which is more affected than the other. Now you can see the withdrawal reflex on the right hind, normal. Withdrawal reflex on the left hind. And now the withdrawal reflex, pinching the fingers on the left front leg. I'll show it again to you. Withdrawal reflex on the back. Withdrawal reflex on the right front. And then withdrawal reflex on the left front. you can definitely see that there is a major difference between the two sides. So the first question for you now is, please, Chiara, where is the problem? Is cervical, thoracolumbar, or lumbosacral? Now you've got a few seconds to answer, and you should pick one of those three neurolocalizations: cervical, thoracolumbar, or lumbosacral, considering how many legs are affected. In a few seconds, we will have the answer. Hopefully, all of you will be right. Okay, so I think that most of you gave the right answer, which is cervical lesion, correct? So just a few of you said thoracolumbar. Try to keep in mind that anytime you got a thoracolumbar lesion, you don't have proprioceptive deficits on the front legs, okay? So for a dog to have proprioceptive deficits on the cervical area, on the front legs, the lesion should be in the cervical spinal cord, correct? So now you should answer to the next question, which is the lesion affecting C1, C5, or C62 spinal cord, cervical spinal cord? Please, Chiara, the next question is C1, C5, or C62. You've got a few seconds, and again, to give the right answer, you have to look at the spinal reflexes, which again, for the front limbs, is the withdrawal reflex. How was it? If it was normal, then was C1, C5, or if it was decreased, then it was C62. Please answer. Okay, this is good, which means more than 70%, so which means about 3/4 of you said that the lesion was C62, and this is the right answer, because the withdrawal reflex was absent on the left front leg. About 25% of you said that the lesion was located between C1, C5, and was based on the fact that the withdrawal reflex was normal on the right front leg. To localize, you should look at the spinal reflexes. If there is a spinal reflexes decrease, then you have to say that the intimate sense is affected. So this is why here you can say that the lesion is C62 on the left-hand side, or mostly affected the left-hand side. So, and this is why the withdrawal reflex on the right front leg was normal, because the right half of the spinal cord is spared. Not all of the right half, because the proprioceptive positioning was decreased also on the right back leg, but the lesion was affecting mostly the left-hand side of the spinal cord, of the lower spinal cord. So C62 on the left-hand side, this is the correct neurolocalization for the miniature schnauzer. A few seconds in case you've got question on this case, and if you don't have question, we move on to the next case. No questions? Okay, so now look at this dog here. Again, anytime you see a dog with the gait issues, you should ask yourself, is he orthopedic or neurological problem? If what you're dealing with is ataxia and or paresis, this is definitely a neurological problem. So look at this dog. This dog definitely has got something neurologically abnormal. And now I'll leave it with you. You should say how many legs are affected. If you compare miniatures now, so with this dog here, you can definitely say that the issue is mostly affecting only 2 legs. I let you say which ones, but look at the proprioception as well. Right hind was absent, so definitely abnormal. Left hind abnormal as well. And you should trust me if I tell you that the proprioception was normal on the front legs. Withdrawal reflex. This is the withdrawal reflex on the left hind from severely decreased to absent, I would say. And this is the withdrawal reflex on the right hind. Okay. I don't know if you want to see the gait again. Of course, it's a very heavy dog. It was an English Bull Mastiff, so, but definitely you can see that there is an asymmetry if you've got doubts between front legs and back legs. He's still able to take steps on the front legs, but he tends to sit down very often on the back legs. So I would say, you have to say that, but I would say paresis on the back legs. Severe proprioceptive deficits on the back legs, and no withdrawal reflex, both on the left hind and on the back hind leg. This dog also had decreased perineal reflex. The perineal reflex is another reflex. We look at the constriction of the anus, which is mediated again by the lumbosacral intumescence, which means L4, S3 tract of the spinal cord. And also the perineal reflex was decreased in this dog. So the first question for you now is, where's the problem? Is a cervical problem, is a thoracolumbar problem, or is a lumbosacral problem? Please, Chiara, and please attendants, give an answer. Is it cervical, which means all 4 legs, thoracolumbar, or only the back legs, or lumbosacral, which means L7S1 issues? A few seconds for the answer. Okay. Yeah, so this is tricky because almost slightly more than half said thoracolumbar and almost half said lumbosacral. When we do refer to lumbosacral, again, the lumbosacral problem, what we may call also coidequina issue, is L7S1. And again, bear in mind, L7S1 doesn't give any paresis, doesn't give any proprioceptive deficits, guys. Either you like it or not, an L7S1 problem, it doesn't give paresis and proprioceptive deficits, and especially paresis and proprioceptive deficits severe, like in the case here. And the reason is because between L7 and S1, as we said already, there is no spinal cord, but there are only nerve roots. And anytime you've got compression of the nerve roots, you've got pain. So if you got the lumbosacral issue, you should have lumbosacral pain, plus or minus lameness or stiffness on the hind legs. But if you've got paresis, like in this patient here, and proprioceptive deficits, the lesion should be located in the thoracolumbar spinal cord. So the correct answer here is thoracolumbar. And then, based on the spinal reflexes, you can say, is a T3L3, which means, is it sparing the spinal cord intumescence, lumbar intumescence or not. So is T3L3 or L4S3? So this is the question, Chiara. Now they should give an answer. A few seconds. So T3L3 means normal spinal reflexes. L4S3 means abnormal spinal reflexes on the back legs. So, which is the answer? Right, correct. So most of you said L4S3, which is correct, which means the lesion is affecting the spinal cord between L4 and S3. Okay, this is correct. So there should be some answers from you. Chiara, do you want to tell me a few answers? Do you want me to give an answer? Sorry, a few questions. Do you want me to give an answer? Okay. So there are a few answers. One answer is the panniculus truncae reflex also useful? It could be, which means if you've got a cutoff of panniculus reflex, or more correctly called cutaneous truncae reflex, if you got a cutoff, which means absent below that level and present cranial to that level, the panniculus reflex could be helpful, but it may be helpful in narrowing down the neurolocalization. Let's say if you said already that is a T3L3, you might say, okay, based on the panniculus reflex or cutaneous truncae reflex, you can say it's more likely to be closer, for example, to L1 or T12. But it doesn't tell you if the lesion is T3L3 or L4S3, okay? So if you localized already based on the gait, postural reactions, and spinal reflexes, if the lesion is located at T3L3, then you can say, based on the cutaneous truncae reflex cutoff, you can narrowing down your area and say the lesion is more likely to be closer to L1. For example, if the cutaneous truncae reflex is absent, caudal to L2, L3. Otherwise, it's not very useful for you to tell you where the lesion is in the spinal cord. Another question, you mentioned in the chorda equina syndrome, you don't have signs of paresis. Isn't low tail carriage signs of weakness? Didn't say that you don't use painful localization? Yeah, that's right. So you have signs of weakness or paresis, but in the tail, as I said, because the chorda equina, as the name itself says, means that you've got problem with the nerve roots going to the coda. Coda is a Latin name for tail. So you have paresis in the tail, affecting the tail, but not the back legs. And of course, if you don't have paresis or ataxia of the back legs, then the only thing you may rely on is the pain. So we don't use the pain if we have neurological signs. So if we do have ataxia and paresis, we rely on them to localize the problem. But if we don't have ataxia or paresis, the only thing we have to rely on is, of course, pain. And then we assess pain to see where the problem could be. So let's see if there are any other questions. Another question is, what is the diagnosis for the Schnauzer? Those are very curious people. We'll give all the answer when we'll look at the different diseases, when we look at the MRI of these guys in the next webinars. But this guy, just for you to spoiler, it had an ischemic myelopathy, what we were used to call fibrocartilaginous embolic myelopathy. Okay. Another question, does hemiparesis mean that there is compression lesion only on the root and not in the body of the spinal cord? No, the answer is no. The hemiparesis means that the spinal cord is affected in the cervical area, which is what hemiparesis means, only on one half or mostly on one half. Okay. Okay, you say L7S1. So one thing you have to bear in mind is that when we do refer to T3L3 or L4S3, we are not referring to the vertebra segments. We are referring to the spinal cord. Okay, so saying T3L3 doesn't mean between the third thoracic vertebra and the third lumbar vertebra. That means between the third thoracic and the third lumbar spinal cord segments. Just for you to give you an idea, the S3 spinal cord segment, so the third sacral spinal cord segments, is more or less located at the level of the sixth or the seventh lumbar vertebra. Okay, this is why beyond that there are only nerve roots. So there are lots of questions. I'm afraid we have to select a few of them. Okay, Christian, L4S3 is lumbosacral, but not thoracolumbar. No, this is not correct, for the reason that I just explained to you. L4S3 is not between the fourth lumbar vertebra and the third sacral vertebra. L4S3 is referring to the intumescence, is referring to the spinal cord segments. And this is why the S3, which is the third sacral segment, is cranial to L7S1 vertebrae. Okay, when we do speak about the lumbosacral patient, is a patient with a disease between the at the lumbosacral joint, which means between the seventh lumbar vertebra and the first sacral vertebra, and the third sacral spinal cord segments ends up more or less at the level of L6, L7. And this is why you have to bear in mind also when you read the books, then when we do refer to T3L3, L4S3, C1, C5, C62, we are referring not to the vertebral numbers, but to the numbers of the spinal cord segments that are cranial in respect to the numbers of the vertebra. I do hope that this is clear for you. Okay, so another question is how you can differentiate between ataxia, mild ataxia, and muscle weakness. Muscle weakness is paresis, okay? Weakness means having the hook or the carpus really flexed, intolerant patients to the exercise, dragging fits. This is weakness. This is paresis. Ataxia means uncoordination. So if you look at the dog from the back and you can see the dog swinging from one side to another, this is an uncoordinated patient, okay? But if you look at the dog stumbling, for example, this is a weak patient, okay? So you have to differentiate between weakness and uncoordination. Another question is, with chorea equina, will you have incontinence? Yeah. Let's say with a really bad disease of chorea equina syndrome, usually end-stage chorea equina syndrome, you can also have either urinary and or fecal incontinence, but this is more an end-stage signs of chorea equina syndrome. So we don't usually rely on that to localize the problem. Yeah, hopefully Matthias Frank understood what I do mean between the difference between vertebrae and neurolocalization. So this is why we don't speak about vertebrae. We do speak about neurolocalization. And when we do speak about neurolocalization, dear Matthias, we are referring to the spinal cord and not to the vertebrae. So L4S3 means that the lesion is cranial to L7S1 joint, and this is why you don't have paresis on the back legs. So yeah, I think we gave an answer to almost all the questions. So there is a lot of confusion between L4S3 and L7S1. Try to bear in mind that lumbosacral patient is a dog with what we may call coda equina syndrome, and the coda equina syndrome means that the lesion should affect the nerve roots of the coda equina, and this is why the lesion should be caudal to L7, so usually between L7 and S1. And when we do refer to the L4, S3, instead, we are referring to the spinal cord segments, and those spinal cord segments are cranial to L4, S3. I'll give you an example of a dog with an L4, S3 disease, for example. So I already gave you the answer, but just for you to be familiar, let me see. So this is a typical dog with the L7S1 disease. So there is no paresis, there is no ataxia. For you to have paresis or ataxia, you need to have a damage of the spinal cord. And the spinal cord, again, ends more or less between L6 and L7 vertebra. So L7S1 joint disease is affecting mostly the nerve roots. And with the disease of the nerve roots, you don't have proprioceptive deficits, as you can see here. The only thing you have is a low tail carriage and pain by the time you reach the lumbosacral junction. Okay, so lumbosacral pain eventually associated with low tail carriage, with incontinence or lameness of the back legs. Those are the signs of a dog with an L7S1 disease. I'll show you one last case. Look at this dog here. This is the gait. The dog is unable to support her weight. I need to lift the dog. So you can easily say how many legs are affected here. The spinal reflexes. The dog has got withdrawal reflex on the back legs. Now look at the withdrawal reflex on the front legs. As you can see, the dog has got normal sensation. So the question is, in this greyhound whippet here, where is the problem localized? Is it cervical, thoracolumbar, or lumbosacral? You've got a few seconds to give an answer. All four legs are affected, so it should be pretty straightforward, the answer. Just a few extra seconds. So, yeah. Most of you gave the right answer, which is cervical, correct? And if I ask you, is it more a C1, C5 or a C6, T2 problem, what would you say? Again, you have to rely on the spinal reflexes on the front legs. Is it C1, C5 or C6, T2? What would you say? Try to remember, if you've got a problem in the caudal aspect, withdrawal reflex should be from decreased to absent. So let's have a look at the answer. Okay, so most of you said C62, which is the correct answer, about 60%, but about 40% said C1, C5. If it was C1, C5, the withdrawal reflex on the front legs should have been normal. Okay, so if the withdrawal reflex is from decreased to absent, then the lesion should affect the intimus sense, which is where is the lower motor neuron, which is between C6 and T2 for the front limbs, and L4, S3, the back legs. Okay, so correct answer is C1, C5. I'll show you one last case to finish off and to say goodbye to you. Let's have a look at this dog here. This dog was referred on a Sunday as an emergency for acute onset of severe paraparesis. Okay, so the dog, according to the referring vet and to the owner, has got severe gait issues on the back legs. Sorry for that. I had to drag the dog to see if the dog was able or not to walk on the back legs. So you can definitely say that the dog has got severe issues on the back legs. Now look at the proprioception. There was the proprioception on the left hind. This is the proprioception on the right hind. So what is neurolocalization? Is it cervical, thoracolumbar, or lumbosacral? Where would you put the lesion? So a dog with this kind of short-strided gait on the back legs, normal proprioception, and no spinal pain as well, just in case you were asking if the dog had or not spinal pain. There was no spinal pain. What was your answer? Is it cervical, thoracolumbar, or lumbosacral problem? Yeah, that was a tricky one. For those of you that said cervical, this is definitely not correct, because on the front and on the back legs, the dog was normal. The key issue in this patient is the dog didn't have any proprioceptive deficits. So it's very unlikely for a dog to be unable to walk, which means paretic, without proprioceptive deficits for a spinal disease. Regardless if it's a cervical or a thoracolumbar localization, if you've got paresis, which means severe weakness with a spinal disease, you should also have proprioceptive deficits. Since this dog didn't have any proprioceptive deficits, if you go back to the question and you ask yourself, how is the proprioceptive positioning? If the proprioceptive positioning is normal, it's very unlikely to be a spinal disease. So you may wonder if it's an L7S1 disease, but as I told you before, with an L7S1 disease, you don't have paresis. And more often, you do have lumbosacral pain. So this dog here, again, was a fake paraparetic patient, which something that you can see in a very acute presentation of a dog with a bilateral rupture of a cranial cruciate ligament. Okay, so always test the proprioception. If the proprioception is normal and the dog seems to be paraparetic, this is unlikely to have a spinal disease and is more likely to have, as you have seen in this dog here, a bilateral rupture of cranial cruciate ligament. Okay, now I'm here for you if you want other couple of minutes for another few questions, if there are other few questions. So let's have a look. There are different signs in case of compression, infiltration, and dorsal spinal cord. Hello, Dr. Fasano, would you differentiate tier 3 or 3 myelopathy associated with spinal shock? Yeah, this is a very good question. So how this is definitely is a very high, this is supposed to be a more advanced level, how you could differentiate a tier 3 or 3 lesion with spinal shock. versus an L4-S3. So basically what this colleague here is saying is that with a very acute and very severe T3-L3 lesion, the dog may experience what is called spinal shock. With a spinal shock, you have an abolishment of the spinal reflexes on the back legs. So the lesion is still in the T3-L3 area, but the spinal reflexes are decreased on the back legs. So one thing that you may use is the cutaneous truncae reflex. If the cutaneous truncae reflex is present more cranial than L4, you can definitely say that this is most likely to be a T3-L3 with spinal shock. Or if you are looking at the dog in the early hours after the spinal cord trauma happened, you can say, okay, this could still be a T3-L3 with a spinal shock, and this is why the dog may have a decreased spinal reflexes on the back legs, or is a true L4-S3. Then if you have to do an MRI, you start with an L4-S3, but since you looked at the dog in the early hours and if you don't see anything between L4-S3, then you move on to investigate the T3-L3 area. And the next question here is how you can differentiate the Schiff-Sherrington between a C1, C5 lesion. This is pretty easy, because if you've got Schiff-Sherrington means that you have a very acute and very often severe lesion in the thoracolumbar area. And if you've got the severe lesion in the thoracolumbar area with a Schiff-Sherrington, you have paraplegia on the back legs. So the dog is unable to move the back legs, or non-ambulatory paraparesis, which means the dog is unable to walk on the back legs, but the front legs are stiff, are rigid. If you lift the dog up and you force the dog to move on, to walk forward, the dog is able to take steps on the front limbs. And if you assess the proprioception is absent on the back legs and is normal as long as you support the weight of the dog on the front legs. So it's impossible, almost impossible, I would say, for a cervical lesion to give such a severe paresis or paralysis on the back legs and normal proprioceptive positioning on the front legs. So it's easy to differentiate a Schiff-Sherrington between a C5, C1 lesion, because if the dog had a C1, C5 lesion, then you should have had also paresis on the front legs and proprioceptive deficits on the front legs as well. So let's see if there are any other questions. Yeah, if you have a monoparesis in the hind limb with absent flexor, how can you differentiate the spinal L4-S3 between an ischiaticus problem? Yeah, so in ischiaticus problem, usually it should be really, really severe to give a monoparesis. So if you have a monoparesis, usually you don't have absence of flexor reflex as well. You have absence of patellar reflex as well. If the patellar reflex is normal and is affected only the flexor reflex, then you can say that probably the sciatic nerve is affected. But if you have, for example, also the perineal reflex absent or decreased, then you have to say that is the half of the lower lumbar spinal cord that is affected. So if you want to differentiate between a pure sciatic problem and an L4-S3, you have to look at the other reflexes. If this L4-S3 is affected only on one half, then not only the flexor reflex will be decreased, but also the patellar reflex and the perineal reflex very commonly. Okay, the last question is if I can repeat the signs of a peripheral damage. So a dog with a generalized, so which means all the spinal nerves are affected. So a dog with a generalized peripheral nervous system disease should be weak or paretic on all four legs, and the reflexes are decreased in all four legs, which is really unusual with a spinal cord disease. So having answered to that, I think I've answered to the last question, and I would say it's all for today. And I really hope to see you in 2 weeks from today with the session for the localization to the brain. So I leave the word to Emilio to finish off.
Thank you, Christian, for the great presentation. And I hope everybody enjoyed the great topic. And I want to remind everybody that they can register already with the link that they are receiving on the control panel. They can receive for the next session that I want to remind everybody is going to be planned in 2 weeks' time. So same time in 2 weeks at 6:30 p.m. for our time. So Dr. Christian, thank you. It's time for dining. I think you're starving. So thank you again. And we'll see you again.
You're welcome.
Thank you very much.
Bye-bye to everyone. Bye. Thanks for having me. Bye-bye.
Bye.